because of the deductibles that you can incur with just having just Medicare A and B, Medicare Part C allows you to do that. So Medicare Part C is like putting A and B together along with D. Medicare Part D is the drug coverage benefit. So what Medicare Part C does, and I know it gets sometimes very confusing, but what Medicare Part C, or what we call Medicare Advantage, and I like to say, what is the advantage of the Medicare Advantage? What it does is it takes your Part A, takes your Part B, it takes your Part D, because now you've got your Medicare hospital doctor visits, you've got your medications, hearing aids, there's an allotment for dental work. All of that is now rolled into, the Medicare Part C program. And usually most Medicare Part C programs, unlike a Part D program or a Medigap program, usually won't carry an additional premium. Okay. That's the big advantage. So to summarize, if you had just Medicare Part A and Part B, you'd have to get a drug program or drug benefit Medicare Part D in order to cover your drugs. And you also have an issue along the lines of having much larger out-of-pocket expense if all you have is Medicare Part A and Part B. Because then you'd have to get a thing called Medigap, or think about getting a Medigap and a Medicare Part D drug program. With Medicare Advantage, you get your eye benefit, you get your dental benefit, hearing benefit, you oftentimes get rides to the doctor, you often get other benefits that you otherwise wouldn't get at no additional cost.
Okay.
At no additional cost.
Okay. So, and how does Zing Health provide all of that? I mean, so what makes Zing Health different from the others? Is what component allows them to bring that together?
Oh. By being a Medicare Part C program, all the Medicare Part C programs, you hear a lot of advertisement on television about Medicare Part C or Medicare Advantage. All the Medicare Advantage programs offer very similar kinds of benefits. And so you could have a Medicare Part C plan that is a HMO kind of plan, or a Medicare Part C plan that is a PPO kind of plan. And those happen to deal with how you move and navigate through the system. And with some you need referrals, others you don't. Some you can go into see doctors that are out of network with a penalty, and some you go out of network depending on the circumstance, and there may not be a penalty. So that's why we ask everybody, and I can give a number, 844-946-4937, which is the number you can call to see what's right for you. And I'll give that number again. It's 844-946-4937. And we also do a Facebook Live on Wednesday mornings at 10 o'clock. And to be able to watch it, just go to Zing, Z-I-N-G, Terry, TERRY.com, and register so that you can watch the live Facebook. And there we have one of our Medicare experts. Her name is Sadia, and she is just a genius in knowing all of the technical ins and outs of what Medicare Part C does versus the others. And I've been with her now for several weeks talking about this. But I can tell you that if you really want to fix your out-of-pocket costs, and depending on what you have or what you elect, you can determine what that out-of-pocket cost would be. That's why you need to call the number that I just gave, because they can speak to your particular situation in a way that I can't do over the television.
Yes, sir. I appreciate you for sharing that. I mean, the way you explain it seems like a lot of components, but it seems simplified when you have the Medicare plan C that incorporates things. But I encourage those in our viewing audience to please call and get more information. Oh, and as a reminder, I did say that this is a live call-in show. If you have a question for Dr. Mason or a comment, please give us a call at 773-434-6625. Again, that's 773-434-6625. So tell me, Dr. Mason, how did you first get involved with Dr. Whitaker and Zing Health? I mean, you're an expert in the medical field, a lot of things, you've seen a lot of programs. So what was it that caught your attention about this particular program?
Well, let me just say this, and that's a great question, Brother Jamal. Dr. Whitaker and I have known each other for a long, long time. I met Dr. Whitaker. I saw him coming into Michael Reese Hospital when he was still in high school. He has always, always been a very strong, staunch advocate for our community in any area that he worked in. At the time, you might remember when I was Commissioner of Health of the City of Chicago, that was the same time that Dr. Whitaker was the State Director of Public Health, and Dr. Martin was the County Director of Public Health. And you had all three major areas of public health covered by three African-American men. Dr. Whitaker was a great help to me as I navigated and began to learn the ropes at the Chicago Department of Public Health. He made certain that whatever resources that he could provide, and this is back during the time of Governor Blagojevich, we worked together on many, many, many things. And Eric has always been a staunch advocate for advocating for Black people, Black men in particular. He worked at county along with other folks to help establish what was called the Black Men's Clinic or Project Brotherhood, along with Marcus Murray and some others. And they took this notion of what a clinic ought to be, particularly as it related to Black men, and changed it in such a way that people, I mean, they took the clinic and they put in a barber to do haircuts. They were teaching Kung Fu. They were teaching all kinds of other activities as part of the clinic to help attract African-American men to come into a clinic. And they were seen by Black male physicians, African-American male physicians that were there. So he's done a lot and also been a very, very large component in my life in terms of helping me navigate the public health situation when I was a newbie to that area. So he's always been a major advocate. And now there's a group called CPAS. That's an acronym for a program that he, and I sit on that board as well with him. He really has put out an opportunity for young people to get exposed to STEM education. And we actually, with this program, provide a early and supportive track for those students wishing to go into the medical profession. We even have a program where they actually get a chance to go in and shadow doctors and things of that nature. It's a wonderful, wonderful program. And one of these days what we should do is probably come in and do a show on that with you, with perhaps one of our students, even if some of our students, if they have to join, even if they have to join it remotely. So he's always been a very, very staunch supporter of trying to make sure that the African American community is not left out. And this effort in the Zing is just another one of those efforts. And he's an African American company that I'm aware of that is now moving into this area. So we have Zing in Michigan. We have Zing in Illinois, different counties in Illinois, different counties in Michigan, moving into Indiana and some areas. He's always been right on the cutting edge trying to do these things. So I can't say too many good things about Dr. Whitaker.
Yes, sir. And we look forward to having Dr. Whitaker on soon, as well. And everything that you say about him, and we know of his track record, has been beneficial to the community. Let me begin to transition a little bit. Of course, we're still in this COVID-19 pandemic. A lot of attention has been given recently to the uptake in numbers of cases, and of course, conversation about a virus. But before we start talking about the virus, I just, as someone who's been out here, just from an awareness standpoint, um, with this COVID environment, have you seen an increased focus, particularly in black men, on prioritizing their health? And I say this because I know that the stereotype, and there was some truth to it, that black men, we rarely went to the doctor unless, we were just, you couldn't walk and things like that. But with everything that's been going on, you think that people have become a little bit more aware or health conscious. And I'm wondering, based on your conversations, your interactions, have you seen an increase in awareness or focus on preventive um, kind of medicine or focus in our community?
Well, we've always been trying to push the prevention envelope. And as you know, there's been many, when you have a new virus for which you have no vaccine, the only thing you can do is practice the public health measures. And those public health measures are making sure your hands are clean, so you don't put virus particles from your hand to your nose and things of that nature. You want to make certain that you try and create distance between you and other people so that there's less likely that you will get that from just close contact. So that's the social distancing. And then the last component of this, as you keep your hands clean, you do your social distancing, you want to make sure that you cover your cough, sneeze, or anything like that, because the virus comes out in respiratory droplets. In other words, stuff that comes out of your lung. And so those things, when you cough or sneeze, if those things aren't covered or protected with wearing a mask, then those virus particles go into the air, and then you can walk by and inhale these things. And then you may or may not get sick with the virus. Most of the people who have coronavirus, that is, most people with a positive test, really don't ever get badly sick. Over 80% of the people that may test positive for the virus, they don't necessarily become very, very ill, but a number of them do. And those are the numbers that you see every single day. And those people who have, from what it looks like, those people who have underlying conditions like diabetes, obesity, heart issues, lung issues, because the virus attacks these particular areas, they are more vulnerable and more likely to end up with a bad result. And even when we say obesity, because there are what are called receptors, there are places where the virus can attach and do what it wishes to do. In our fat cells, in our lung, all of those areas. And that's why people get so violently ill. This is a very, very bad virus. And until we have a vaccine that we can distribute, and there'll probably be others, you've heard about the 2 that are out there now, but there'll be others, and we have to take a close look at those vaccines. We have to, in fact, the 2 that are out there right now, these are vaccines that are using a totally different technology for creating vaccines. And this new technique is something that we don't know as much about as we'd like to, because it's not been what we normally use. Usually, like for some of the other viruses, we use sort of a killed copy of the virus to stimulate our immune system to attack it when it comes back in our body. This new virus doesn't use that technique. It uses a totally different technology, and I can't say it's good or bad just yet, but I just know that it's new and we don't have any long-term history about using it.
Let me ask you, why is the purpose for the new technology for the vaccine? Is it because of this particular virus type, or is it because the need for an aggressive vaccine, or to hurry up and put it in production?
You know, brother, it's probably a bit of both.
Yeah.
I can't say exactly why. I'm not a virologist, but I'm going to get more information about that. But this is something that has been not necessarily using a copy of the virus itself. It's using a totally different technique. Now, whether this is a new technique that we're going to see in vaccines going forward, I don't know. But I do know that we do not have a long-term history with this technique as we do the others. And what we have to always be concerned about is what is the long-term potential side effects from this vaccine, and will this new technique create other problems that we're not yet aware of? Now, we have not at least heard much about this in the phase 3 trials. And the issue is, because this disease is doing what it's doing, there has been a rush to try to get a vaccine out as quickly as possible. But we do need to step back and take the time. And you might say, well, maybe we don't have that much time with what this virus is doing. But we still need to be clear about what we have, what we can expect it to do, and what we don't know about it just yet.
Thank you for that. Dr. Mason, let me ask you this. Now, with this vaccine, with the information that you have now, is the vaccine supposed to be given, is it more of a preventative thing, or does it attack the symptoms and help you, does it treat the disease or help prevent the disease, the virus?
The latter. It helps to prevent you from succumbing to the disease. All vaccines work on the prevention side. In other words, what happens with our vaccines, like what we try to have for flu and what we had for measles and polio and all these things, what it does is it sort of primes your immune system. So with a copy of something that looks like the virus that's going to cause the disease, let's take, for example, one of the things that we commonly get vaccinated for. And when we do the match for looking for the flu virus, we try and get a strain of the flu that we think is going to be circulating in America at this time. The reason we do that is because by getting the shot, we give ourselves a weaker form of that virus. And then what we want our immune system to do is to read it. And then if we get that virus coming into us later, we already have the cells in place. Our armies are already ready to attack that and sort of neutralize it or kill it before it can do the things that it needs to do for us. That's sort of the oversimplification version of explaining what the vaccines or what all vaccines do. Okay. Same thing is true for the shingles vaccine. Same thing is true for, mumps. Same thing is true for measles. Same thing. That's the same process that's used for all of these vaccines up till this point with this new one.
Okay, right. I think we have a caller. I want to go to the air. Caller, you're on the line with Dr. Mason.
Assalamu alaikum, Brother Jamil.
Alaikum salam, Sister Marta.
And also to you, Dr. Mason.
Alaikum salam, Sister Marta.
I have a comment and question. My comment is as far as side effects of medication. I'm a transplant patient, and I was transplanted 4 years ago, and I'm still suffering from the side effects of my transplant medication, Myfortic at the time. And that's a proven long-term medication that's been on the market. And for them to put this vaccine out in such a fast pace without all the data, as far as enough lessons that have been learned for the side effects, to me, is frightening. My question is in regards to what you spoke of first, about Medicare Advantage. Why is it so hard for transplant patients to actually be on Medicare Advantage? And because of their tier 1 and 2 and 3 type of medications that sometimes are covered, or they're covered very cheaply, if you will. And you have to have a lot of out-of-pocket expenses, and Medicare Advantage doesn't end up being free or no deductible type of thing. So if you can speak on that, I'd appreciate it. Thank you.
Well, Sister Marta, you were kind of garbled, so I couldn't hear you as well as I would like to hear you. But what I would do, if you have some specific questions, if you're a renal transplant patient, you automatically get Medicare, and then that would automatically put you in a situation where you could take advantage of a Medicare Part C program. With regard to the specific questions, I would ask you could call and speak to maybe the person at Zing Health would be able to help you navigate some of those other issues. And that number is 844-946-4937. It's 844-946-4937. And they can walk you through the specific and or particular issues that you have, because you mentioned transplant medications. These things are also usually very expensive, but I think in order to get the right answer, you should ask those right people.
Yeah. You know, Dr. Mason, Mr. Marta brought up a good point, and it's widespread. Everyone knows, you know, as far as in this day and age, having so many side effects and things that we're used to traditionally or historically. There's so much unknown with this virus. And I'm trying to think back in my time, you know, has there been a virus that's been incrementally rolled out? I know you've had the testing and everything, but now with this one, of course, it's going to go to maybe some of the first responders or some that are most vulnerable, and then may be made available to others later on. And I just really don't remember new vaccines being introduced. And so is this the traditional way they're usually rolled out, or is this, again, a special circumstance because of the impact of COVID-19?
Well, that's a great question. And I think that there are, even when we had the H1N1 back in 2009, there were what we call priority groups. And these priority groups were women and young children who we wanted to get the vaccine into first. And that's because usually you don't have enough right away for everybody. So you want to make sure you prioritize those most in need, those that will be the ones most affected, and therefore need to be among the first protected. So it is important that roll out in that way. And that's what's going to happen with this vaccine as well. And it's going to take time. I mean, just for the state of Illinois, there's about 12.8 million people in the state of Illinois. It's going to take time to roll this out. And not only that, but right now with the two candidates that we have from Moderna and Pfizer, you have to get 2 injections. And you get 1 injection, and then you need another injection a couple of weeks later. So it's going to be, it's going to be a bit of a logistical thing, and the state departments, and the State Department of Public Health, the CDC, all of them are working together to come up with a plan for how this happens. And so the rollout may have a few bumps in the road as we go forward, but we won't be able to vaccinate everybody in a day. That's not going to happen. This is going to take some time. It's going to be, people are going to have to be patient. Just like if you look at the long lines that people have now just to get testing. Now, we know that we should have had testing rolled out a long, long time ago, but that didn't happen. But we are where we are, and we have to operate within what we have to work with at this point in time.
You know, you mentioned the cross-departmental relationships, CDC, the Department of Health, and ultimately, is it a collaborative decision on the rollout of this plan and deciding how the vaccine is distributed, or is there one overriding or governing body that is that final decision maker in that process?
That's a great question, and let me explain how it worked out for the last pandemic we had, which was the H1N1.
Okay.
First of all, what you understand is that the CDC, the Centers for Disease Control, is the national public health organization. The CDC, since it can't physically be everywhere, delegates its authority to do what the CDC does to the states. Each state has a public health director. In this case, Dr. Ezeki, you've seen her on, and Dr. Whitaker in the past. You've seen Dr. Arnold in the past. Those are the state health directors. But their orders, all these orders come from the CDC. Then the state director oversees the other directors of public health, whether it be in the city or in the county. So if you look at the authority, it goes, we're all working for the CDC. All the local health departments, the state health departments are all reporting up to and taking instructions from the Centers for Disease Control.
Okay, excellent. And the next question, brother, with that, and I appreciate you taking the time to explain these things, because it's important, especially in this forum, to make sure that our viewers are aware. As far as pricing and costs, I know that these are private pharmaceutical companies who have created this vaccine, but is there any regulation or caps or things like that that are put on from a cost perspective, especially in lieu of a pandemic, because the vaccine has to go out to so many people?
Well, first of all, let me say again, with the experience I had with H1N1, no individual person paid for a vaccine.
Yeah, okay.
The vaccines are bought by the federal government by way of the CDC. The CDC then buys and distributes the vaccine to the state health departments. And then the state health departments, based on their plan, will either work with the local health departments at the county and city level, or what may happen, there may be other people hired to help facilitate, as there probably will be in this case, because it'll be an overwhelming job to get the vaccine administered, whether they'll use private doctors, whether they'll use drugstores like CVS and Walgreens and what have you. That's all part of the planning that will come down with the authority from the CDC to the states to the local health departments.
Okay. Excellent. Excellent. Thank you for that information, because, I was curious about that. And, now that I don't recall when I was younger. Well, I wasn't paying for it anyway at the time, I don't think, but just in case, because you have to ask these questions in this day and age. Let me ask you, how does the recent change in the administration, how do you think that affects it? And this is why I ask. And, I'm not a conspiracy theorist, but I know that leading up to the election, all the conversation was that we probably won't have a vaccine this year. I know that the former president, Trump, was, early on talking about we would have something this year, and all the sentiment was that we would not. But then about 2 days after the election, I think Pfizer was the first company to announce something, and so ever since then we've been hearing about this vaccine. Does the change in administration, is it going to affect people in position at the CDC and all of that, or is we can still expect a smooth rollout with these vaccines, or what? How does the change in administrations affect this rollout with the vaccine?
Well, first of all, you're right. I mean, the directors are usually appointed by there are some governmental appointments. I think President-elect Biden has a great team. And unlike the previous administration, I think that he's going to listen closer to what the recommendation of the scientists and the people who have to get this done will say that needs to be done. We will not probably have the sort of political influence to make it look as though everyone is doing something special. I think that the two companies that have come on, there are many other companies. There's Johnson & Johnson, there's other companies that are going to make this, but we cannot sacrifice safety for speed.
Yes.
We cannot do that. We need to be certain that the CDC is given the time to make certain and for the appropriate review. That's why these two companies have filed for what's called a EUA, an emergency use authorization. What does that mean? That means that some of the process is streamlined in order to make certain that this can be made available as early as possible based on the analysis of the research data to show, first of all, that it's safe.
Mm-hmm.
And now there's obviously, because we're in the throes of the pandemic, there is a deeper sense of urgency to get these vaccines out and into the people. Okay. But we can't allow that sense of urgency to override safety. And so that's a delicate balance that the people at the CDC, the National Institutes of Health, the other scientific organizations have to make certain that they keep those things in balance.
Okay. And as we continue, because when you answer one question, it only stimulates another. So,
all right.
And I appreciate it. But, early on, President Trump would say something like, he would give masks or assistance or funding to one state versus the other. So with this vaccine and the CDC is, I know, and it might be based on population and need, but are all the states accounted for, or how are they prioritized? Is it based on the population and need, or is it politicized? When it's a vaccine, the CDC has control of distribution, but they're responsible for dealing with the state, as far as the state health directors, all 50 states, right?
Correct.
Okay.
And what happens, Brother Jamal, to further amplify what you're saying, is that the rollout is not going to be homogeneous across the country, because the country is not homogeneous. Right. You have some very rural areas. I mean, you got to remember that you have some very densely populated areas like Chicago and other cities within like New York and other places. So there may be some differences, but the other thing that we have to realize is that the question of, we don't have enough vaccine right now,
right,
to make sure that every person gets it. So there's going to be a rollout that hopefully now that President-elect Biden and his team have finally begun the transition process, that they can begin to look at this far more closely and come up with a scheme to get it all done as fairly as possible.
Yeah.
And I think that there'll be people watching because all of these things are in a fishbowl. You'll be able to see almost everything that's going on. And I am prayerful that the politicalization of it is something that will not be as much of a factor as we've seen in the past. But we do have limited supply at this point. Mm-hmm. Many of these companies are trying to ramp up production as quickly as possible, but we cannot let the speed of trying to get this overweigh making certain that these things are as safe as we can possibly have.
Okay, great. We're going to go to the line. Caller, you're on the line with Dr. Mason.
Assalamu alaikum.
Wa alaikum salam.
Dr. Mason, this is Shahid calling. I saw something on the news that they said, I think they had 3 companies that had a vaccine that was out. Now, they all had different prices of what the vaccine was going to cost to,
I can't understand what. Can you repeat the question?
He was saying, Brother Shahid, speak up a little bit, please.
Okay, Dr. Mason.
Yes, sir.
I saw something on TV where they had 3 companies that had vaccines out, and all 3 of them was charging different prices on how much the vaccine would cost. But what I'm trying to find out, now with the general, if you got a vaccine shot, would you have to pay for it, or is the government going to pay for everybody? Because if not, somebody going to get rich.
Right. Well, all I can tell you, Brother Shaheed, because I don't know all of the details in terms of how that's going to roll out. I can tell you that our experience that we had with H1N1 back in 2009, the government bought all the vaccine. It went to the CDC, and the CDC distributed the vaccine to the states. And then we got the vaccine. And I know no one was charged to get vaccine back during that time. So it is something that was totally paid for by the government. We had these mass vaccination areas where people got their shots, and it was all done under the direction of the local health departments. What the rollout is going to be now is, I think, something Dr. Ezekiel and her team and the governor are all working on, trying to figure this out. There's going to be some mixed reaction. There'll be people who want to get it quickly, and there'll be some people who won't want to take it at all. And so what we'll do is we'll have to see how this unfolds. And as we get more vaccine available, that will be less of a problem. It's only going to be a problem now because there's going to be priority groups only because the vaccine is not in wide supply just yet, but it will get there.
Yes, sir. Thank you. We're going to continue with the line with the calls. Caller, you're on the line with Dr. Mason.
Assalamu alaikum.
Wa alaikum salam.
Good to see you guys. Hey, brother Mason. They had some speculation that this virus, since it had not been used in the trials so much on black people, that it may not have the effect that it would for white people. That's one of my concerns. And I heard this from this sister watching Brother Wasim's show last night. And I guess another thing would be the distribution. You know, once again, how is that going to be handled in our community? And I guess you can see why we have this kind of fear of vaccinations and things from the government. I'm gonna hang up and listen.
That's a great question, brother. And let me tell you that someone who has been involved in clinical trials before, and we've always had, not just with this vaccine or this medication, but we've always had an issue of trying to recruit African Americans to trials. When I was in practice, we actually put together a group of researchers who wanted to specifically work with African American populations to encourage us to be a part of these trials. And when I was in practice, and some time ago, when a lot of the Viagras and the Levitras and the Cialises and all those things came out, we had to put together some special trials to target African American men, because you're right, we did not have enough African American men in the majority trials in order to be able to make any safe assumptions about what this was going to do for us. Now, theoretically, it shouldn't be that much different, but we always need to be sure. And so there is still going to be, and of course there's difficulty. People are afraid. People don't know what this is going to do. This is a new vaccine. We are living in a time where we've seen the alt-right and all kinds of other people come forward with all kinds of positions. And we've seen situations where we've had black people just killed. We see the legal authorities being abused, particularly in the police departments and things of that nature. Not all over, but in many cases, and I'd be not true if I didn't say something about that. But what we have to do is, at the end of the day, what we have is what we have. And we need to, that's why we've had, the minister did call together folks to try and look at this and try and come up with some positions on the vaccine and what have you. But I think that all we can say right now is we can only work with the information that we have. And to the extent there were some black people in both the Moderna and Pfizer trials, The other many of these trials are taking place in other countries where we don't know what the breakdown is in those other countries. Some are taking place in countries like India and some things on the African continent as well. All we can do is get the information that we have, make that information available to people. And unfortunately, the one question we still cannot answer is the long-term side effects, because we haven't had it for a long term. We're going to have it out there for a while to know and be able to document what the long-term side effects are. Mm-hmm. Now, in the phase 3 trials, and that's the phase that these trials are in right now, we have some data, but we don't have enough. And it was particularly on the African Americans, because we were afraid many of us were afraid, as well as other people. Black people weren't the only people afraid, but we only can talk about what we have. And then I think that we have to be clear, transparent, and honest about what we have, what we don't have, and then people have to make their own decision about what they choose to do.
Thank you for that, Dr. Mason. We're going to take a break for a moment, and we're going to come back on the other side with more interesting conversation from Dr. Terry Mason. We'll be right back.
It's against your own health. That how creates more diseases in your body than you have any dreams of. In fact, about it, stop eating the hog, eat right, eat the proper food, and you will find 75% of your sickness leaving you. Just try it.
I love you, Emma.
Assalamu alaikum, and we are back. I'm your host, Jamil Muhammad, streaming live with Dr. Terry Mason as we continue our conversation on this COVID-19 virus. Not virus. Well, the virus and the vaccine, brother. So we'll do that. Hey, but let me ask you a question, brother. I want you to make the distinction here. In the news also, we've heard recently that treatment might be the cocktail or whatever that they gave to President Trump might be something that they use to treat people that have COVID. So I know that's not a vaccine, but now I'm hearing conversation about that being a potential treatment for some patients?
Well, brother Jamil, what I want to say about that is we all saw what happened with the president, at least what we saw on television.
Yes, sir.
And one of the things, there were three things that the president got. One was a cocktail made by a company called Regeneron, and that was the monoclonal antibodies. Those were the antibodies that we're talking about. He also got very high doses of a steroid. That steroid we've been using for a long time. Steroids are anti-inflammatory things, and they help sort of try and control the inflammation. And then, of course, he also, in addition to the Regeneron in addition to the Regeneron cocktail of monoclonal antibodies and the medications, the steroids, those were the two main things he got. He got a third thing too. But the two things that the one thing you're asking about are the monoclonal antibodies. And they're now using those, and the other one he got was remdesivir, the other drug, remdesivir, which was a drug actually made for Ebola. And they've been using it because they didn't have anything else, and so they tried this one because it was a virus as well. So the remdesivir, they allowed more folks to use it now. The monoclonal antibodies now, Regeneron is the company that has to make that and get that up to speed in terms of its production. At Cook County, they were using a similar cocktail. I think it was made by Regeneron too. These are all things that are new, that many of them have not even been through sort of the trials that the vaccines have been, with the exception of perhaps remdesivir, because they used it for some other things. So we're just using it for a different indication now.
And also, these are things that you'd have to pay for on this one, right?
I'm not sure.
Okay.
It sort of depends on where you are, how they decide to use it. I'm not sure. I know that it is not commercially available.
Gotcha.
The Regeneron cocktail is not commercially available. The steroids have been around forever, so those are like any other medication. And the remdesivir is also like any other would be charged like any other medication that would be charged for its use. So those are the three things that are going on right now. Whether or not how those things are all going to be charged for, particularly the Regeneron cocktail monoclonal antibodies. These are antibodies that are in the plasma. If you take your blood, it's actually made of multiple things. But if you were to put it in a test tube, put it in a centrifuge and spin it around, it would separate. And the stuff at the top, if the blood is not clotted, that's the area where those antibodies are located, and what we call it's in the plasma, what we call the plasma. Mm-hmm. So whether or not that becomes what we use, it's all new. It's all new. And I think the reason most people realize it because the president had access. He went to Walter Reed, he's president of the United States, and based on what he was reported to have had, they threw the book at him, so to speak, to see if they could get him well as quickly as possible. The steroids, the steroid is we use that all the time. It's very effective with the people with asthma. Sometimes people who have bad asthma oftentimes will get a prescription for the steroids. So, and oftentimes it helps to sort of calm down the inflammation in the lung and make it easier for people to breathe. And as you know, people who get COVID, particularly the respiratory part of it, the bad respiratory part of it, that's why they end up on ventilators, because they can't breathe. And so the air has to be actually pushed in and forced in so that it can go into the circulation by the pressure that the ventilator exerts in trying to get this air into the body. And also because of the fluid and all the other things that happen, people have to be turned They have to be prone. They have to be turned from laying on their back to laying on their stomach to allow these fluids to better drain. It's called proning. There's a lot that goes into the work in taking care of a particularly very ill patient who has COVID.
Okay. Let's go get this last caller, this segment, Dr. Mason. Caller, you're on the line with Dr. Mason.
Hello?
Yes, sir. Caller, you're on the line.
Yes, assalamu alaikum.
Walaikum salam.
Yes, my name is Minister Ben Willis, and I was just listening to the show. I was doing a multi-gamut of things, and yes, about the COVID and the vaccination for that. The way the history has been in this country, and especially with black people and vaccinations, it makes you almost skeptical to even go down that route. In fact, I spoke to a gentleman that's in his 70s. He told me, he says, I'm not going to take no vaccination. Let all the other people take it. And if they take it, then I guess I'll be okay, because I guess if it won't spread or if they drop, I'll be all right. So it's just a point of having faith that any of this stuff even existed. I mean, as far as what President Trump would say he took, how do we know? All of a sudden now it's vogue for everybody to say I got the COVID vaccine, but no one's really fast on saying I got syphilis or gonorrhea. I mean, this is just, it's like a dog and pony show to me, and I would be very skeptical on taking any kind of vaccination.
Yes, Minister Ben Willis, I know that there are others who share your sentiment. We talked about the hesitation and reluctance earlier on, Dr. Mason, based on our history and experience in this country, brother. But we're running out of time, my dear doctor. The hour has come to a close, but you will come back and join us again, won't you, brother?
Yes, sir. And I'll say this very quickly. Food is killing more of us than anything else. And I want folks to understand that.
Yes,
and
sir.
so if we really want to talk about doing better, we do need to learn how to eat to live.
Yes, sir. Brother, I'm glad you said that. It's so taught by the Most Honorable Elijah Muhammad. We all need to adhere to that and do a better job. Dr. Mason, thank you for joining us.
You're very welcome. Thank you very much, Brother Jamil.
Yes, sir. All right. Brothers and sisters, I hope that you've enjoyed this evening's broadcast with Dr. Mason. Very informative show. And before we leave, I'd like to extend my condolences to my wife, my mother-in-law, on the loss of their aunt and sister, Miss Ernestine Barney. She's a very kind woman. She passed away this weekend. And also to my dear brother Carlos Muhammad, I'm glad that you're okay after that episode yesterday, brother. May Allah bless you all with the light of understanding. I leave you in the greetings of peace and paradise. Assalamu alaikum.